everyone. My name is Jimmy Bowen, one of the PEDS chief residents, and I have the pleasure of introducing Dr. Priya Kishnani this morning for Grand Rounds. Dr. Kishnani is chief of the Division of Medical Genetics, Department of Pediatrics, and director of the YT and Alice Chen Center for Genomic Research, which has a focus on developing new therapies for rare genetic disorders. She holds certification from the American Board of Medical Genetics and the American Board of Biochemical Genetics. Throughout her career, Dr. Kishnani's primary focus has been the translation of laboratory science into the clinical arena, especially in the area of such therapeutic interventions as enzyme replacement therapy, gene therapy, and small molecules. She has propelled the translational research program at Duke with the T1 to T4 impact, implementing bench-to-bedside approach and from the bedside back to the bench for further advances towards the diagnosis, treatment, and management of patients with rare genetic diseases. Dr. Kishnani has built an interdisciplinary team whose efforts are most notably demonstrated by the long-standing research and clinical experience that resulted in an FDA approval of alpha-glucosidase alpha, or Enzyme, as the only available treatment for Pompe disease in 2006. Welcome to Dr. Kishnani.
Thank you, Jimmy. And I'll just, I'm really pleased to be able to present at Grand Rounds. And I'm just going to get my presentation ready. Can you see this clearly? Is this okay?
Dr. Kishnani, we are not seeing your slides yet.
You're not seeing my slides? Hold on. Is this good?
That looks great.
Perfect. So good morning, everyone, and thank you for the opportunity to present for Grand Rounds. In Pittsburgh, I have many dear friends and colleagues there, and I hope that this talk really inspires many of the younger people in the audience of what we can do in the field and the lessons that I can give you that I've learned in my journey in the past 30 years at Duke. So these are my disclosures. And as Jimmy pointed out, the importance of integration of patient care and research, recognizing that things don't just go from bench to bedside, but also there's a crosstalk from the bedside to the bench, is really critical in advancing therapies. So I'm going to give an example through the glycogen storage diseases, an area that I have focused on and where Duke has a very rich history for the past 50 plus years. So the glycogen storage diseases, or GSDs, are genetic deficiencies that result really in the storage of material called glycogen. And this glycogen could be abnormal in its amount, but also abnormal in its structure. And there are more than 15 plus GSDs in the literature that have been reported to date. So key concept for all of us is when we eat, we are storing energy, and when we fast, we're releasing the stored energy, and really energy equals glucose. I think another context and another concept to remember is that extra glucose that we have is stored as glycogen, and glycogen is nothing but multiple polymers of glucose, and it's highly branched as a structure to allow more retention. And the idea that glycogen is stored primarily in the liver and the muscle, but the function of glycogen in these two tissues is different. In the liver, it's really to maintain glucose homeostasis. So during a fast, there is release of glucose from the glycogen for key organs like the brain, the muscle, and the red blood cells. But when we are trying to exercise and we need short bursts of energy, that's when muscle glycogen is released. So when we are fasting and shortly after a fast, if we really pay attention to the patients, within a few hours of a fast, what really occurs is the utilization of glycogen or breakdown of glycogen by a process known as glycogenolysis, to release glucose. In the next several hours of the fast, we are dependent more on ability to get glucose from amino acids by a process known as neoglucogenesis. And then in the later stages of the fast, we're starting to use fat by the process of ketogenesis. And you have a lot of expertise at Pittsburgh with this, with Dr. Jerry Barkley, Georgianne, and others. So really getting a good patient history gives you an idea where a disorder could be. If it's in the first few hours where you're starting to see hypoglycemia, you know that this likely is a disorder of glycogenolysis. So again, looking at a snapshot of these glycogen storage diseases, want to point out that all these disorders are due to deficiencies of enzymes in the cytoplasm of the cell, with the exception of one, which is a lysosomal enzyme deficiency or glycogen storage disease type 2, also known as Pompe disease, and this is due to acid alpha-glucosidase deficiency. So the idea is to break down glycogen to glucose. You need two key enzymes, phosphorylase, which breaks down the outer branches of glycogen, and then debranching enzyme, which breaks down the inner branches of glycogen. And to synthesize glucose to glycogen, you need two key enzymes, actually three now, glycogenin, glycogen synthase, and branching enzyme. So I'm just going to give you a snapshot of a few of them to tell you the important lessons that each one of them has taught us. So glycogen storage disease type 1, also known as von Gierke disease, is autosomal recessive. The estimated incidence is about 1 in 150,000. And there are two major subtypes, type 1A, which we see in about 80% of the cases. And here the enzyme deficiency is glucose 6-phosphatase. The key message to again give is that this enzyme is expressed in high amounts in the liver, in the kidney, and in the intestinal mucosa. So you can now start to think where the manifestations of this disease would occur if there is an enzyme deficiency. Without this enzyme, the glucose 6-phosphatase cannot be converted to glucose. And so you can imagine that if we are stuck in glucose 6-phosphate without the ability to make glucose, the patient is going to experience low blood glucose. So this is going to be one of the only ones that I'm going to show you a pathway, but the importance of recognizing where looking at a pathway, you can really understand the metabolic sequelae. So here is glycogen being broken down to glucose 6-phosphate and then finally needs to be converted to glucose. And this requires the enzyme glucose 6-phosphatase. So when this enzyme is deficient, patients manifest with GSD type 1A. And you can see that when you have a perturbed pathway with buildup of glucose 6-phosphate, it gets shunted further down, makes pyruvate, as a result of which you can make a lot of lactic acid. You can also end up with the hypoglycemia because of inability to make glucose. And then there's a buildup of acetyl-CoA, and so you have increase in lipids. And then there's also a shunting into the pentose phosphate shunt, and you can make an increase in uric acid. So just by looking at this pathway, you already recognize what a patient with GSD-1 is going to manifest with: hypoglycemia, hyperlipidemia, hyperuricemia, and a lactic acidosis. So again, this condition is because of an inability to make glucose, and there is a shutdown in both the breakdown of glycogen to make glucose, as well as an impairment in making glucose by the process of neoglucogenesis. So the sequelae are very severe because these patients cannot make glucose unless it's provided from an outside source. So typically these babies, again, another important lesson is when a baby is first born and is constantly feeding, there is no result in hypoglycemia. But at the time of weaning, when the baby is now starting to sleep through the night and there is no extra source of glucose being provided from the outside, is when they start experiencing the irritability and actually the symptoms and signs of hypoglycemia. They, of course, also have an increase in their liver size because of the accumulation of glycogen and fat in the liver. And so now, again, As I pointed out, if you have a disorder of glycogenolysis and also a challenge with neoglucogenesis, you have to really feed these children very often, every 3 to 4 hours, to provide an outside source of glucose. So another lesson learned by just looking at a pathway and by knowing where the block is. So this is a patient that we had seen at Duke many years ago, has short stature, has profound hepatomegaly, and this is a child with GSD type 1. So in terms of an intervention, I've already given you a clue that you need an outside source of glucose to prevent the hypoglycemia and to maintain levels above or equal to 70 milligrams per deciliter. And if you avoid this fasting, you can correct the metabolic derangements. So how can one do this? The treatment strategy as we know it today is from argo cornstarch, which is nothing but polymers of glucose, but it needs to be given in an uncooked form, because if you cook the cornstarch, you're going to release or break down those bonds. And so now you have free glucose and you won't have the impact of this cornstarch. So the idea is you provide this at frequent intervals to maintain normoglycemia. And the concept of this, of providing cornstarch, really came from the early 1980s by my mentor, Dr. Chen. And this was a landmark paper in the New England Journal of Medicine, which showed that if you took cornstarch or if you took other kinds of starches like polykose or rice starch, what really maintained the blood glucose in these patients with GSD type 1 was really best achieved with the uncooked cornstarch. So once again, what was done was doing it in tap water or at room temperature, because again, if you used hot water, you're breaking down the cornstarch. And another key lesson that was learned is that if you use it in very young babies, if you have low pancreatic amylase, we have maturity of it at a year or older, you're not going to be able to utilize the cornstarch. So another key lesson learned from this simple experiment, and that if you gave the cornstarch every few hours, every 6 hours at a particular dose, you could really maintain normoglycemia or normal glucose. So we changed the natural history of glycogen storage disease type 1 just through frequent feedings, but not requiring them to be on a continuous glucose source, but now here through giving cornstarch to these children. They now have lived into adulthood. And at this point, many have achieved puberty, many have gone on to have children, but we're learning the natural history of this disease and the phenotype over time. So these are 3 individuals with GSD type 1, and we've lost 2 of them. One of them because of the failure of a kidney transplant, which was needed for this patient. A second, the other patient, because had developed benign, or what was considered at the time benign tumors in the liver, and a third, as you can see, who lives but now is status post liver transplant. You can see that even as a young boy, he has an NG tube in place. So what we learned as we followed these patients over time is that there were long-term complications which occurred. They could still have some short stature. They could have a delay in puberty. Some of them could develop gout. If you remember, I showed you that there can be a high uric acid. They can have high lipids. But the key message, again, to point out is that we learned a lot about these benign growths, as they were called, hepatic adenomas. And then through work of following these patients, we realized that there was an increased risk for hepatocellular carcinoma coming out of these hepatic adenomas. And so this was a case series that we published with many in the field. And we recognized that these hepatocellular carcinomas really had an etiology which was different from the general population. It really was at the site of these benign tumors, which were found in patients with GSD type 1, or what was called benign tumors, and that markers of HCC like AFP and CEA are not reliable because they are often normal in the setting of hepatocellular carcinoma. So I think we learned from this that we now needed to do much more for our patients with these patients with GSD type 1, and the need for new therapies, that long-term complications occur, and that diet therapy does not cure GSD type 1. So then the next step was to use a next generation of cornstarch, because the Argo cornstarch, as you can imagine, is like taking tablespoons of that cornstarch. It's very pasty and not particularly palatable for patients. They can often have side effects in terms of abdominal bloating and diarrhea from it. And so a second generation cornstarch called Glycosade is now available. And this is required in smaller amounts, has fewer side effects, and also gives better glycemic control. So this is now used for the management of patients with the glycogen storage diseases. And you can see that experiments were done looking at two groups of patients, one which were on cornstarch therapy, and the second which were put on this modified or next generation cornstarch. And you can see that the peak with conventional cornstarch, so they can get hyperglycemic earlier on, and that the extent of maintaining normal glucose levels is less than when you use a next generation or the experimental starch. Of course, these lessons also showed us that not every patient tolerates the next generation cornstarch, and also that the longer duration that we say works was done in very small numbers of patients. But nonetheless, we have an alternative. So now can we think about an approach to provide the missing enzyme? And so this currently is in the clinic, but the idea is if you can provide liver-directed gene therapy with the human transgene, the idea was that regulated glucose 6-phosphatase expression in the liver would restore normal glucose levels. And so for this, one needs mouse models, and one also needs larger models of the disease. So this is the GSD-1A mouse, which was developed by Janice Chu at the NIH. And again, looking at the natural history, these mice become very hypoglycemic and they can die. The majority die even before 6 months of age, and it mimics human disease to a certain extent, but they don't have the lactic acidosis. But now we also know that they can have the adenomas that we see in patients with GSD type 1. So here you can see the GSD-1 mouse, much smaller than wild type mice. And so this is a colony and work from Dwight Coble from our group at Duke. And also then the lessons from a larger model. So given our GSD diagnostic lab, a vet had reached out to us and told us about some dogs that had large livers and were dying at a very young age. And so we actually tested for the enzyme deficiency in our diagnostic lab and identified this mouse model, or this dog model with GSD type 1 in Maltese dogs. And this was work that I did as a trainee and isolated the sequence and also the pathogenic mutation. And this is now this dog. So we crossbred it into a beagle so that we could have a larger size than the Maltese dogs. And you can see the profound hepatomegaly in these dogs. And now this is just how much better these dogs can do. And they can maintain normal glucose levels. And this is now in the clinic in terms of translating from the bench and taking it to the bedside. Of course, this was work done in collaboration and with David Weinstein and at that time Dimension Therapeutics and now Ultragenics, and is currently in phase 3 clinical trials. But I think what we've learned is that some nutritional therapy is still needed to supplement these patients, and that this is more correcting the liver. We need to see how to address the kidney complications still in this disease, and we need to await the results to know the best gene therapy treatment for GSD type 1A, but to show that one can start with simple therapies. Majority of patients are still on cornstarch. You can manage the long-term complications with good follow-up of these patients, and now we are in the clinic with gene therapy. Now going on to the next disease, or a GSD type 3, which is due to debranching enzyme deficiency. This is now, as the name suggests, to break down the glycogen to release glucose. And again, to give you an idea, this is the glycogen structure with glucose, with the glucose phosphate. And this is a branch point of the glycogen. And you can see that to break down glycogen to glucose, you first need the phosphorylase enzyme, which breaks down the outer bonds of the, or releases the outer glucose molecules. And then we are stuck with these 4 molecules of glucose, which requires debranching enzyme, which releases the glucose by 2 actions, by one enzyme, by the debranching enzyme. It first moves these outer glucose molecules into the straight chain and then releases the branch point. So long and short is 2 enzymes are needed, phosphorylase and then also debranching enzyme. The debranching enzyme is needed for the inner branches of the glycogen and also to release the branch point and make glucose. So the idea would be that if you have debranching enzyme deficiency, you have limit dextrins, which are building up here. So short outer branches of glycogen. And as you can now see that here you have buildup of glycogen, which is abnormal in quantity, but also abnormal in quality. And there are 2 major subtypes. Again, this was work that was pioneered at Duke to recognize these 2 subtypes. One, where there is the enzyme deficiency both in liver and muscle, which accounts for the majority of patients. But then the second subtype, or GSD-IIIB, where it's only deficient in the liver. And once again, this is due to the presence of one pathogenic mutation in exon 2 by the new nomenclature that results in this protection, and in patients are developing 3B and not 3A. So patients with type 3 can have the enlargement of the liver. They also have the low blood glucose because now there's a difficulty in glycogenolysis on in breaking down glycogen to glucose. And here you see an increase in the liver enzymes. This is because of the abnormal structure of glycogen that's accumulating. And as I said, they can have some amount of muscle involvement, which is both skeletal muscle as well as cardiac muscle. And so the difference primarily from GSD type 1 is that these patients have an increase in the liver enzymes. They also have the increase in the lipids, but not as much as in GSD type 1. And here you can have a progression to liver cirrhosis, again, because of the abnormal structured glycogen. And the adenomas are not as common as GSD1. So fundamental differences, if you're at the bedside, is they don't have lactic acidosis, they don't have the uric acid issues or the hyperuricemia, and they have intact neoglucogenesis. And so they would have a normal glucagon response 2 hours after a carbohydrate meal. Of course, we don't do this, but to let you know that the disorder is more because of structural abnormality of the glycogen that is building up and a disorder of glycogenolysis. So different from GSD1, where it's both glycogenolysis and neoglucogenesis, which are a problem. So for the treatment of GSD type 3, again, you can figure out it's less demanding than type 1. But once again, the use of uncooked cornstarch. So again, a lesson from one rare disease being applied now to another rare disease, use of cornstarch, but also looking at the pathway, knowing that neoglucogenesis is intact. So one can give these patients a high protein diet to help them out, to maintain glucose levels, and also to help with trying to prevent a progression of the skeletal muscle disease, which we see in these patients. And some of these patients require liver transplant if there's end-stage cirrhosis. So again, the therapies are symptomatic. And this is the GSD3 phenotype over time. You can see when they are younger, they have a significant enlargement of the liver. And over a period of time, there's a decrease in the size of the liver, which is not necessarily a good thing. This is because of the progression of liver disease and more scar tissue and a progression of fibrosis to liver cirrhosis. Again, lessons that we have learned. And then these are older patients with GSD3. You can see this individual in a wheelchair and also has wasting of the small muscles of the hand. So again, the use of small and large models, just in the interest of time, pointing out a naturally occurring dog model for GSD type 3, again through our diagnostic lab, where we identified dogs with GSD-3 who were becoming hypoglycemic, but also had increase in the liver enzyme and also an increase in the muscle enzyme CPK. And so what we found is that this canine model really closely mimics what we were seeing in human disease. And so we now have a naturally occurring model for this and a colony at Duke, which has allowed us for therapy learnings and next steps. So for the human liver disease, again, if you read the literature, it often says that these symptoms improve with time. And yes, that is true. But what is going on is a silent progression of the liver fibrosis. So liver enzymes, which tend to be increased when the children are younger, and they tend to normalize over time. This is because of progression, similar to a NASH or other conditions where you have a progression of fibrosis and cirrhosis. And then in terms of skeletal muscle disease, it becomes more manifest in the third or fourth decade of life. And there's both a proximal and a distal muscle weakness, and some patients end up in the wheelchair. So we do need a more definitive therapy. So gene therapy with AAV, we are working on this, but here the gene is too large to be packaged into AAV. And so at this time, an mRNA approach is being used, but this would only address the liver issues. It's put in a lipid nanoparticle, but as we know, if you've got underlying liver disease, you could actually provoke, an increase in hepatic enzymes. There could be complement activation, and we're only addressing the liver issues. So still lessons to be learned. And again, we have a mouse model and also have a larger model. So allowing, for more experimental work to be done. Now here is another concept which we took from diabetes, where we use continuous glucose monitoring. And so we said, can we do this in the management of glycogen storage diseases, given that otherwise these patients constantly have to prick their fingers to get glucose recordings, and how often can one do this? So in the past, we used to admit these patients and do constant finger prick by the hour, but we know in today's world of telehealth and also the challenges with admitting patients, this seemed like another next step in terms of progress. So this is again work which came out with a lot of support from our endocrine team at Duke and my wonderful dietitian Surekha Pendial. What we looked at was we looked at patients with GSD-I, GSD-III, and GSD type 9 and tried to see how much time did they spend in normoglycemia, and were we missing periods of hypo or hyperglycemia. And again, the point is to tell you that across the board with the different glycogen storage diseases, there was a period of time that these patients were spending in less than 70 milligrams per deciliter, which was being missed by traditional methods of fingerstick glucose measurement. A majority of it could be in the overnight time frame, but there were also periods of time that they were spending in hyperglycemia or an increased blood glucose levels where they were above 150 milligrams per deciliter. And so by using the continuous glucose monitoring method, we are now able to better monitor these patients, and we can use the Dexcom G6, which downloads directly for us to be able to give advice to these patients without having them coming into the hospital and improving their care. The other key that we did is that we looked at the correlation between the continuous glucose monitoring and the fasting, the fingerstick blood glucoses, and you can actually see a very nice correlation here. So once again, this has made it now into clinical practice, but also is part of clinical trials, as is being used now by Ultragenyx in GSD type 1 for their clinical trial of gene therapy. So now I'll switch gears for a moment and talk about the only glycogen storage disease, which is also lysosomal storage disease, which is GSD type 2 or Pompe disease. And what you'll see here is a small amount of glycogen is transported, we believe, from the cytoplasm into the lysosome. We still don't know this transporter. We have worked on it at Duke, and there is a transporter called STBD1, but we believe that this is only for the liver and not really for skeletal muscle. And so this glycogen, which is seen in the lysosomes, is broken down by this enzyme, acid alpha-glucosidase, or GAA, and which, when deficient, results in GSD type 2 or Pompe disease. So this is, again, a collaboration with many through the years, but based on the amount of residual enzyme, there can be an infantile form of the spectrum called the infantile form of Pompe disease. And these patients in the past, we said, were in the first few months of life, but now I've changed it to the first few days of life. And I'll come back to this and explain why I say this. These babies present with hypertrophic, thickened heart, and they die within the first year of life. And then there is the rest of the disease spectrum, what we call late onset Pompe disease. And the only separation between infantile and late onset is the absence of cardiomyopathy in the first year of life. So these patients really present as a limb girdle muscle weakness, and they have early involvement of the diaphragm, and so they have significant pulmonary issues and can have early respiratory failure. This is again to show you a month apart for babies with Pompe disease in progress. And you can see a 4-month-old, a 5-month-old, and 6-month-old. And that I'm sorry, I was unable to.
You usually was sitting down.
You can see the sickness
Sitting down.
and
Can you hold up your head a little bit?
to the disease.
Up by
And you can
yourself.
also see large
Toes.
these babies.
Toes.
So as we were thinking about this disease, we recognized that this was a significant unmet need, and we needed to understand how to treat this disease. So this one slide, again, cost us more than $1 million across collaboration to show that the natural history of this disease was that first signs and symptoms were recognized at about 2.7 months of age. A diagnosis was made on an average at 6 months of age. They ended up on a ventilator at 7 months of age, and they died by about 12 months of age. So this was really much needed as we
go all the way down past there.
And this is late onset, again, to show you.
And then come all the way back?
From a child to an adult, you can see to an adolescent.
And one more time.
The Gawa sign.
Okay. Now what about coming down? What do you usually do? You usually hold on. Coming down can be even scarier.
Support for walking.
Don't do anything that doesn't
All
feel
due to
safe.
the same enzyme. Time, you know, there's a spectrum of residual enzyme activity in these patients, no cardiac involvement. So in terms of a treatment for Pompe disease, there was nothing until 2006. And again, this is a collaboration between bench and bedside and multiple centers across the world. There was just supportive care, but for the infantile form, no matter what was done, these babies died by a year of age, as I showed you. And this is really to tell you how patients impact us. And this is baby Carmen, who really was our bench to bedside story and the catalyst here. So this little one, as you can see, is African-American. There's a higher frequency of infantile Pompe in the African-American population. The family had limited means, and at the time, there was nothing that we could offer other than maybe a bone marrow transplant. So the family started to raise money, and by the time, you know, there was sufficient funds, this baby had really advanced and succumbed to the disease. And so returning from the funeral, a decision was made by Dr. Chen, Johan van Hove, who was a trainee at that time, and myself, that this was not going to repeat itself. And that's where the concept of trying to provide the missing enzyme came about. And the concept was that if you provided this missing enzyme intravenously and found a way to target it to the lysosome, could we really clear the glycogen and rescue the phenotype? So it's a concept which we can think about as providing insulin to someone with diabetes. And many of you now treat the mucopolysaccharidosis Fabry disease But this was, and Gaucher disease, but this is a muscle disease where you are trying to traverse and get to 40% of the body, which is muscle. So in those days, there was no mouse model for Pompe disease. And so we had quail birds which were affected. So a quail colony was started at Duke. And this was again a collaboration with Japan. Quail eggs were brought here. And the colony shows, if you can see, that the weak quail birds could not fly. But after receiving the enzyme, they were able to right themselves and actually fly. And there was also a clearance of glycogen. So this was the first proof of concept that this therapy could work. And based on this preclinical work and the unmet need in these infantile cases, an open label study was started at Duke, again to tell you that you don't require too many if the data are strong. So only 3 patients were enrolled. And out of these, 1 did well and 2 did very poorly. Again, to tell you, each patient in a rare disease teaches us something. And these were the data that the heart improved in all 3 of them. You can see the chest X-ray before and after treatment. But what we saw also was a very nice clearance of glycogen. All this pinkish material here is in skeletal muscle and a clearance of the glycogen. But over a period of time, we saw that 2 of the patients deteriorated and actually died. And here is a picture. This little boy was the one who did well and is actually now 21 years old, has graduated from college. And this little one succumbed to the disease, the first ever patient that was treated with enzyme treatment with the CHO, with recombinant enzyme. And this was a commitment made to that family that we would try and find reason why this little one did not do well. And just to tell you that because of that success of 1 patient, the program was acquired by Sanofi Genzyme, and a Pompe map was built out with the idea that clinical trials would be initiated in the infants with Pompe disease, and then we would also work with the adults with Pompe disease. And so 18 babies were enrolled across the globe. And again, you can see that they were all younger than 6 months when they were started, and this was after a year of treatment. I hope I can show you that the outcome is so significantly different on enzyme treatment versus the natural history, but there is a variability of response with some who learned to walk, but some who were just able to crawl, and then some who were alive, as you can see to the bottom right, but were not doing well. So that's where, translational research and crosstalk really helps. And so we embarked on trying to understand what was going on. But nonetheless, with those data, this therapy was approved by the FDA in 2006 as the first neuromuscular disease. But really, for those of us as pediatricians, this was the first time, we were now taking lessons learned from the infants rather than the trickle-down impact from adult conditions and adult therapies, which then has a trickle-down impact on babies. And this drug was approved, and then we also did adult studies in patients, to show that the benefit was also noted in patients with late onset Pompe disease. But then, as I showed you earlier, these children, not all of them were doing very well. And we were now trying to figure out what were the reasons for this. So the first thing is that if you don't treat in time, just a few days later makes a huge impact. Who was treated by then what we call early symptomatic.
Okay, come back.
Okay, coming back.
Versus someone who was started later.
Come back. Run it back.
Now able to give up, but is
All right. Close. Open.
Open. Look at the hand.
Is very important. Then we also looked at histology and realized that if the glycogen comes out of the lysosomes, you're not going to have an impact. So it's the stage of the disease and also age of the patients, which means the stage. And then going back to that original patient that I showed you that succumbed to the disease, we went back to the drawing board and realized that he had 2 deleterious mutations in the gene. and which resulted in no residual enzyme activity. And from there came the concept of cross-reactive immunological material negative, where there is the absence of protein on a Western blot. And so you can see here is if you have no protein right there, that's what we call CRIM-negative. And these patients would treat the enzyme as a foreign agent and thus would mount an antibody response to that enzyme, as compared to those who have some residual protein, those which you can see here highlighted, what we call CRIM-positive. And those patients tend to do better than the CRIM-negative patients. So that very first patient, again, the crosstalk between bench and bedside allowed us to learn this. And so then we went back and looked at cases through the clinical trials and recognized that CRIM-negative patients were mounting an antibody response to the enzyme treatment compared to the CRIM-positive patients. And this really translated to a much poorer outcome, that they initially responded, the heart responded, but then over a period of time, they succumbed by about 28 months of age, despite enzyme replacement therapy, versus the CRIM-positive patients who continued to do well. So this concept of CRIM has now been translated to other rare diseases in terms of our learnings and in terms of treatment. So again, going back, that first patient 101, who I said had succumbed to was CRIM-negative, and now compared to a CRIM-positive baby, and you can see the difference in outcome. CRIM-negative
Yes.
ended up on a ventilator. The CRIM-positive baby who was started early is actually doing very well, even at 9 years of age. So this came up with another concept, which I'll talk with you in a few minutes. So now, trying to resolve this problem, our team worked on looking at I'm not an immunologist, but felt the unmet need. So looking at how antibodies are generated, recognized that there is T cells, B cells, and then plasma cells. And so when a therapeutic protein is administered, it's taken up by the antigen presenting cells. And then with helper T cells, you're starting to make antibodies. So in the interest of time, again, as a concept, our concept was that if we could block this pathway right at the outset, could we rescue the phenotype and prevent antibody generation in babies with Pompe disease? And we actually developed a protocol using a B cell agent and a T cell agent, and said if we did a short course of these agents, so rituximab, which is a B cell agent, and methotrexate for a short period of time, but continuing with the enzyme treatment, could we prevent that immune response and tolerize these patients? And I'm just going to show you, again, as a reminder, this is our CRIM-negative patient who was treated with enzyme therapy alone. And this is a CRIM-negative patient in Israel who was treated with enzyme therapy plus the immune tolerance protocol, just 4 doses of this rituximab. And you can see that we have changed her phenotype in the sense that she's alive, doing well, and again, looking at the patients who just received enzyme treatment, they mount significant antibody responses, but the patients who receive the immune modulation, and this is actually a global effort and collaboration, including with many of my dear friends and colleagues at Pittsburgh, we were able to show that these patients who are CRIM-negative, who receive the immune modulation protocol, do not mount an immune response and do well. And so this now today, through sheer tenacity, I took it back to the FDA, and today we have a label change where now there is a package insert which says that CRIM assessment has to be done for infantile cases and that the consideration of immune tolerance induction needs to be done. So again, lessons from rare diseases, few cases teach us a lot, but allow us to move ahead. And so now in closing, when talking about T1 to T4 research, we recognize that even a few days of life in terms of a delay in terms of diagnosis costs a baby either being on a ventilator or not, or being able to walk or not. And so we nominated Pompe to be on the recommended uniform screening panel in 2008. It was finally approved in 2015. And today there are 24 states, and I know Pennsylvania is one of them, where Pompe is on the recommended uniform screening panel and babies are being screened there. And this is the kind of outcome you can see. This is a CRIM-negative baby who was started actually at a couple of days of life. This is her at 2 months of age. This is her at 3 months of age. You can hardly see a head lag. This is her 2.5 years on enzyme treatment with immune modulation and early start of therapy. This is her at 3.5 years of age. So we can definitely impact these patients when we start early and with the newborn screening approach. And so there were very, very important lessons that we learned from newborn screening again. Prior to the start of newborn screening, our assumptions in terms of disease frequency was 1 in 40,000 births and babies presenting in the first few months of life, because that's what we knew. But then once newborn screening was started in the different states, the frequency now is anywhere from 1 in 9,000 to 1 in 24,000. And today we recognize that even right at birth, on day 1 of life, these infantile cases have cardiac involvement and treatment can be initiated very early. They can have a much better outcome, but yet there can be residual disease. So we need to endeavor on. There are next generation therapies that are available or becoming available. Some of it is now through clinical trials, but some of it will be available. The concept of substrate reduction therapy exists. Gene replacement therapy exists. And so the idea of enzyme treatment is you have a peak and a trough because you have to constantly provide the enzyme. It's taken up by the lysosome, and then based on the half-life of the enzyme, there's a drop in the level of the enzyme and a need to re-intervene or give the enzyme. But if one was to do gene therapy, there would be a continuous source of enzyme. It could correct the enzyme deficiency. And if one used a liver-directed approach, maybe we could prevent an immune response to it and result in very stable levels of GAA so that it could be provided to these patients. And this is currently in phase 1 clinical trials. Different sponsors are working on it. Duke is also working on it. But I just wanted to close by stating that what I present here is 30 plus years of work, of working collaboratively with the bench and the bedside, and at the bedside working with multiple specialists and keeping really at the center of it the parents, the patients, and the care coordinators, learning to say, I do not know, and going back to the drawing board, but really very, very important lessons really from the concept. Simple concepts can be life-saving, like the concept of using cornstarch and even the use of continuous glucose monitoring. Everything does not have to be very fancy to rescue a patient. The concept of cross-reactive immunological material, which now has been considered for other rare diseases. The concept of earlier treatment also for other treatments. The concept of clinical trial endpoints of invasive ventilator-free survival that we use for Pompe has now also been used for SMA. The concept of immune modulation being used not just in the space of enzyme treatment, but also in the space of gene therapy. The key from natural history studies cannot really go, in a cavalier way, straight from animal studies to patients. The role of working together and collaboratively, but also recognizing lots of unfinished work and the art of working together and knowing that every patient teaches us something to expand on our work. And for us at Duke, we currently, of course, continue our work on GSD-II or Pompe disease, but really now focusing on many of the other glycogen storage diseases, type 3, type 4, type 6, and type 9. And so would love to continue the collaborations with all of you at Pittsburgh and from around the world. But also, I would be remiss if I did not thank the team at Duke, our various funding sources, the patients, and then, of course, the various cores at Duke, our subspecialists, and then a global community of physicians, including many at Pittsburgh as well. And then, the learnings from our trials our first patients, the humbling experience of when you first see a child taking a backpack and going to school, or a child celebrating his or her first birthday, or doing milestones as simple as sitting and blowing a candle. I think that's what drives us to the field of medicine, but also a recognition that we lose many along the way. And this is a quote from a patient, Helen Walker, who had the late onset form of Pompe disease, was in Australia. I had met her on one of my journeys there. And this is artwork, which was her way of expressing herself. She's actually succumbed to the disease, but this is how she felt. She said that the butterfly spends the greater part of its life in a cocoon, and then it escapes and flies off to start a new life. And the different types and colors of the butterflies represents our patients with Pompe, but you can take it in a broader sense of our patients with rare diseases from around the world. And the liftoff signifies the hope and the freedom of life. So I think this is really what keeps us engaged in the field. And thank you for your time, and I would be glad to take any questions.
Thank you very much, Dr. Kishnani. We have a question from Dr. Vockley in genetics. First, he wants to thank you for the inspiring description of your journey with these diseases and the benefits of the patients that they receive. He's wondering how you see our healthcare system dealing with the costs of therapies for these expensive treatments for these diseases.
Jerry, it's exactly a very good point. And, when we did one rare disease at a time, the healthcare system could absorb it, but now there are so many rare diseases and so many treatment approaches for these rare diseases that we definitely need to work on a more sustainable platform. So I completely appreciate the comment. And I think you also work in the rare disease space, and we're working towards more, towards therapeutic approaches, which are a one-time for these patients, which could drive these costs down and improve, of course, the quality of life of these patients as well.
Dr. Mazumdar is wondering how frequent the enzyme injections are and if there is a specific estimate of the cost.
Yes, so very good question. And the package insert dose for Pompe disease is 20 milligrams per kilogram every 2 weeks. Now, remember that this is a muscle disease, and so you're trying to target 40% of the body. But through our learnings, we have seen that some of these patients are getting it at 40 milligrams per kilogram per week. We've published on this. I don't have any stocks or anything with Sanofi, but I've done this more as an unmet need for the patients. And so many of them are now on weekly treatments for it, and that has definitely improved the outcome. And that's where the whole goal of next generation therapies, which could have better targeting to the skeletal muscle. And in terms of cost, for a baby, it would be about 100,000 a year. For an adult, please don't completely quote me, but it would be in the 200 to 300,000 per year range. This is in general for enzyme treatments.
Priya, this is Jerry. I think that, oops, I think I can turn my picture on. They allowed me to unmute here and talk directly to you. That was really a great talk. Thank you. Do you want to do a little advertisement for the NIH program that's going on currently that you've been involved in? I think there'll be folks who are interested in it.
I didn't hear your question very well, Jerry. Let me mute myself.
I was suggesting that you give a little advertisement for the NIH therapies for rare disease program that's going on now that you've been part of.
Absolutely, the TREND program, yes, and NCATS. I mean, we've had a lot of support, as we've gone along the way. And for sure, in terms of scaling up, even for vector production for AV, Dwight has received support for it. Absolutely, yes.
And let's see. I guess we have a couple more minutes. I think the most impressive thing about what you've done at Duke is that you've been able to build your clinical trials into your clinical practice. How does that work in real life? Because it's hard to sometimes differentiate whether these patients are on a trial standard of care or need to go on something different.
Jerry, that's a very, very good question. What we have really tried to do is we try and separate the two, but we have to integrate it because these are rare disease patients coming from across the country. And so what we consider as part of clinical research, we have them signed to natural history studies and also for interventional, like physical therapy assessments, which are not considered, say, standard of care. We still try and get them to do it during that visit, but parcel out the time. It does require a little bit of art work and art form, but I do have a CRC, directly in the clinic consenting the patients. And then we also have a number of medical students, interested in research who help us in these natural history studies and participation. But I think that's the only way one can do it is to try and take the lessons from the real world and then build on it, in the space of clinical research. And we've had a lot of support from Duke on this. The other nice part about Duke is that we've got a phase 1 unit allowing us, to go right from phase 1 to phase 4 clinical trials, and also a wonderful infrastructure for clinical translational research.
I think that's all really critical. Let me ask you one more question here, then I guess we'll go off to the Meet the Speaker session. Newborn screening for these disorders has been revolutionary for the ones that have therapies, and has driven the development of new therapies that, however, are not yet approved. How do you see the interplay between potential for therapy, the need to identify patients early, but a newborn screening infrastructure that really isn't up to identifying all of these disorders all at once?
Jerry, another great question, and it falls on us, right, as the pediatrician or the geneticist. Once something is put on a newborn screening panel, and there are so many lessons that we learn. The serodeficiency allele, the identification of variants of unknown significance or uncertain significance, what do you really tell families, the counseling aspects which come from it, and then if there is not a therapy, how do you, what do you do really sometimes for these patients? But I think there is a wonderful NIH session of the importance of early treatment. In fact, today is workshop session 2, which I would encourage people to join, of how can we really move the field forward? Because I think the bottleneck right now is in the clinicians, able to take on these patients identified by newborn screening. But the idea is there clearly is a benefit. We've seen this, right from our conditions, fatty acid oxidation disorders, amino acid disorders, and now with the lysosomal diseases. I didn't have time to even show you, but some of our so-called late onset patients who we thought present like, in the second decade of life, we're actually finding phenotype in them already in the first year of life. But the idea is we do need more support, to allow for this to become a success. And so we've got to be cautious in our approach as we keep adding conditions to the RUSP.
Thanks. I'm going to turn it back over to Jimmy to wrap it up.
Yeah, thank you both very much. I think we have a few more questions in the chat, but I think we may have people join in the meet and greet session with the link in the chat now. Thank you, Dr. Kishnani.
Thank you.